All right, let's dive right in. We're doing a high-yield board review on Tinea Capitis in adults. The goal here is simple: to lock in the essential, must-know principles you absolutely need for your exams and for your clinical practice.
So here's our game plan. We'll start with the foundation, the why, the pathophysiology. Then we'll move into the investigation, which is all about diagnosis. After that, the main event, systemic therapy. We'll also cover adjunctive management, and then wrap it all up with some high-yield pearls that are perfect for board review.
Okay, first things first, the foundation. Let's get into the pathophysiology. Really understanding the why behind the infection is what makes all the treatment decisions we'll talk about later make perfect sense.
So what are we actually talking about here? Let's be really precise. Tinea capitis is a fungal infection specifically of the scalp and hair, and it's caused by a particular type of mold called a dermatophyte. For your boards, the two names you have to remember are the big ones, Trichophyton and Microsporum.
Okay, this is a huge distinction for your boards, so really pay attention here. We're talking about the pattern of hair shaft invasion. You've got two types. First is ectothrix. Think ecto for outside. The arthrochonidia form a sheath around the hair shaft. This is your classic microsporum. Then you have endothrix. Endo for inside. The arthrochonidia actually invade the hair shaft itself. This is what you see with species like T. tonsurans. And listen, this isn't just some academic detail. It's a game changer because it completely dictates what you'll see clinically and how you're going to treat it.
All right, let's shift gears to the investigation. This part is all about how we move from just suspecting something is wrong to getting that confirmed diagnosis. This is a core competency, and you'll definitely see it on your exams.
Being able to recognize the different clinical looks of Tinea capitis is super high yield. So on the non-inflammatory side, you have things like gray patch, which are these scaly bald patches, black dot, which is exactly what it sounds like, little black dots from broken hairs. Then there's moth-eaten alopecia, pustular types, and even a diffuse scaling that can totally mimic regular dandruff. But you absolutely have to know the severe inflammatory forms. We're talking about kerion, that's a deep, boggy, pus-filled plaque, and favus, which has those classic cup-shaped crusty lesions we call scutula. Trichoscopy is fantastic because it gives us these great, non-invasive clues. The first one to lock in is comma hairs. These are tiny, broken hairs that are bent into a C shape. For board purposes, when you see comma hairs, you should immediately think Microsporium canis. It's a really strong association. The next finding is corkscrew hairs. These are, well, shaped like a corkscrew, helical. Now, unlike comma hairs, these are a bit less specific. You can actually see them with both Microsporum and Trichophyton infections. It's also worth noting that they're particularly associated in the literature with African American children. And finally, we have black dots. This finding corresponds directly to that black dot clinical type we just talked about. Under the dermoscope, what you're seeing are so-called cadaverized hairs. They're broken right off at the surface. Now, see how this all connects? This finding is a hallmark of that endothrix invasion pattern we covered, which means you'll primarily see it with organisms like T. tonsurans and T. violaceum.
So, how do we get that definitive diagnosis? You've got choices. A KOH prep is super fast, but honestly, its sensitivity isn't great. Fungal culture is the classic. It'll tell you the exact species, but it's slow. We're talking 3 to 6 weeks. That's why PCR is often the way to go. It's fast, 24 to 48 hours, it's highly sensitive, and it gives you that crucial species ID. And here's the key point. Identifying the pathogen isn't optional. It is absolutely essential for guiding your therapy.
And that brings us perfectly to the main event, pathogen-guided systemic therapy. This is the absolute core of managing Tinea capitis. Your choice of drug is not random. It has to be tailored specifically to the organism you've identified.
Okay, if there's one thing you take away from the treatment section, it's this table right here. This is the decision point. It's pretty straightforward, actually. If you're dealing with a Trichophyton species, remember, that's our endothrix pattern, you're reaching for terbinafine. It's your first-line go-to agent. On the flip side, for Microsporum or Nananzea, the choice is different. You're going to go with either itraconazole or griseofulvin. You absolutely have to commit this to memory. Pathogen dictates therapy. It's that simple.
Now for the nitty-gritty, the specific regimens for adults. For terbinafine, the dose is 250 milligrams daily, and you're looking at a 4 to 6 week course. For itraconazole, it's 100 to 200 milligrams a day for 4 weeks. Fluconazole is another option. You can do 50 milligrams daily or 150 milligrams weekly for anywhere from 4 to 8 weeks. These are the numbers you've got to know cold.
Now, you know, systemic therapy is the star of the show, but it doesn't work in a vacuum. We've got to talk about adjunctive and topical management. Think of these as the essential supporting cast.
So this brings us to a question that trips a lot of people up, and it's a classic exam trap. Can you manage Tinea Capitis with just topical therapy alone? What do you think?
The answer is a hard no, unequivocally. This is a critical point for your boards. Why? Because the infection is deep down in the hair follicle and the hair shaft itself. Topical agents just can't get there. They can't penetrate deep enough to actually cure the infection. So their role is strictly as an add-on, an adjuvant to the systemic therapy that you have to use.
So what are these recommended add-on agents? Well, we're talking about medicated shampoos. The guidelines point to three main ones: selenium sulfide 1%, ketoconazole 2%, or cyclopyrox 1%. And the protocol is very specific. You apply it, leave it on for 5 minutes, do that twice a week for about 2 to 4 weeks. The whole point here is to reduce the number of spores on the scalp and cut down on how infectious the person is.
Okay, let's wrap this up by integrating everything with some high-yield clinical pearls. These are the kinds of concepts that pop up in tricky board questions and are just plain vital for smart clinical practice.
So what do you do when your treatment isn't working? Don't panic. There's a logical sequence to follow. Step 1, always make sure the patient is actually taking the medicine. Confirm compliance. Step 2, go back to square one with your diagnosis. Reevaluate the pathogen. Did you get it right the first time? Step 3, armed with that info, you switch the drug based on the confirmed bug. For instance, if you have M. canis that's not responding to griseofulvin, a good switch is to itraconazole. Or for a stubborn T. torrens Sanders, you might switch from terbinafine over to itraconazole.
What about blood work? Do we need to monitor labs for these systemic drugs? Well, it's a bit nuanced. For any patient with a history of liver problems, or who's taken other drugs that are tough on the liver, or who has other significant health issues, yes. For them, you're going to want to get liver function tests before you start and then check again after 2 to 4 weeks. But for healthy patients without any of those risk factors, there actually isn't a clear consensus. It's really a case-by-case decision you make with the patient.
Finally, let's nail down 3 public health takeaways that are super important. First, screening. If you identify an anthropophilic species, like T. tonsuranus, you need to screen family members and close contacts. Asymptomatic carriers are really common. Second, school. For a zoophilic infection, one from an animal, a child can go back to school right away once they're on therapy. But for an anthropophilic one, from another person, they need to wait 1 week. And third, prevention. You've got to deal with fomites. Combs, brushes, hats, all that stuff needs to be disinfected or just thrown away to stop the spread. And at the end of the day, why does all this detail matter so much? This quote from the source material really hits it home. The stakes are incredibly high. Delayed diagnosis or inadequate treatment can result in scarring alopecia. We're not just talking about a temporary problem. We're talking about preventing permanent, irreversible hair loss.
So we'll leave you with this final thought to chew on. We're seeing more and more antifungal resistance popping up in other dermatophyte infections. That should make us all stop and think. How can we start applying the principles of antifungal stewardship right now to make sure that the treatments we rely on for Tinea Capitis today are still going to be effective for our patients in the future?